It's a special treat to be able to introduce our keynote speaker for this meeting. David Blumenthal is the National Coordinator for Health Information Technology in the Department of Health and Human Services, but that really does not adequately describe this extraordinary individual. David, immediately prior to this, was on the faculty at Harvard at the Mass General, where he was the Samuel O. Thier Professor of Medicine, which is very important to me personally because Sam Thier was both my chief resident and my predecessor as president of the Institute of Medicine, so it's a very prestigious title. But David has had an extraordinary career. He was educated at Harvard College and the Harvard Medical School, but while at the medical school, he also obtained a master's degree in public policy from the Kennedy School. He has been a practitioner, so he understands the issues that challenge the practice of medicine and the use of technology in that practice. He's a health policy expert and has had a health policy institute first at the Kennedy School and then at the Massachusetts General Hospital for many years. He's a distinguished investigator, was the founding chair of Academy Health, which some of you will know is the national organization of investigators in health services research, and he's the recipient from them of their Distinguished Investigator Award. He's had legislative experience, and coming from Massachusetts, he was able to get into the late Ted Kennedy's office in the 70s and never lost his interest in the political arena and has been very active in that area ever since, being a major contributor to policy by presidential candidates and others. Some people don't realize that he's an historian and was co-author of a very interesting book on health and politics in the Oval Office, the role of presidents in healthcare. And for me, one of the important contributions of David Blumenthal in his enormous body of research, I think over 200 papers, is his strong commitment to the integrity of medicine, the integrity of science. He's written extensively about the role of industry and its relationship to academia, not saying that it shouldn't happen, by no means, but rather emphasizing how and on what basis that collaboration can be carried out in a way which is honest and open and does advance knowledge and truth with regard to drugs, for example, without undue concessions to the sponsors in industry. He's written and been interested in public advertising of drugs and the implication for patients. There is this thread throughout his research career of trying to see that the right thing is done for patients and is therefore of particular importance given the sensitivity, as we've discussed this morning in terms of health information technology, to be sensitive to the needs of patients and the public, that having this individual as the national coordinator is a blessing so far as the United States is concerned. It's my pleasure to present to you Dr. David Blumenthal.
Well, Ken, thank you for that very generous introduction. It reminds me of the time when Eleanor Roosevelt was introduced by a Republican, and being a very modest but very accomplished woman, she said, "Please keep your introduction short." And so the gentleman said, "This is Eleanor Roosevelt. The less said about her, the better." I also can't think of anyone I'd rather have introduced me than Ken. Ken has been a model of many of the characteristics that he attributes to me, a leading academic, a leading manager, an influence on healthcare policy and thinking through his role at the Institute of Medicine, and there at the Institute of Medicine, shaping through his personal intervention and interest and actually Institute of Medicine funds, discretionary funds, two of the most influential reports in the history of modern medicine, To Err is Human and the quality chasm report at the Institute of Medicine, which are now almost cliches in medical parlance. They are so often referred to. So I think Texas is very fortunate to have brought him here to run your University of Texas system. I also want to thank Vivian for this opportunity. It's a pleasure also to get to know Ambassador Dejarian and to hear a little bit about his service to the country. And you have a terrific panel of contributors here today. I'm sorry I can't be here for all of it. It's great to be in Texas. You are such a big and important state for our aspirations at the national level with respect to healthcare. You are a vital part of the picture. Your importance is reflected actually in the investment that our office, the Office of the National Coordinator, is making in Texas. We have put close to $100 million of our funds. I'm not talking about meaningful use. I'm talking about discretionary funds from the Office of the National Coordinator. In the last 6 months, we have invested close to $100 million in Texas through grants to the state to promote health information exchange, to support of 4 regional extension centers, through a $15 million grant to the University of Texas to work in precisely the area that Bill Stead was talking about, cognitive support for better decision-making by physicians. We're supporting the development of curricula for health information training, and we're supporting health information training at Texas community colleges. So I could actually probably spend a month here trying to figure out what all this money is being used for and still not do due diligence for the work that you have ahead of you. And I know that $100 million is probably not enough given your size, political diversity, geographic diversity, from sparse, rurally populated areas to this medical megalopolis that we're in the middle of right here. But it's $100 million that wasn't on the table 6 months ago. So we hope it's a start, a kickstart for you in this community, throughout this state, to take and run with as you go forward. Now, one thing Ken didn't emphasize in his introduction was my knowledge of health information technology. And that was very wise on his part, because, in fact, the only reason I have this job is because I was a primary care physician who had to use an electronic health record. I had no particular interest in health information technology until that happened. I had no particular training in it. As a matter of fact, my wife thinks it's hilarious that I have this job because she takes care of the computers at home. But I did have the experience of using an electronic health record. And though I wasn't looking forward to it, it wasn't on my list of to-dos when it happened. I was trained in the paper world, and I was very comfortable in the paper world. Once I was forced, not by the hospital that developed the record, but really by my peers, who were somewhat younger and took to it like the proverbial ducks to water. Once I was forced to use it, I came to see that it was truly making me a better physician. And the thing that was most important to me was not the mechanics of recording and having the information, though that was valuable. What was most important to me was the decision support that was available to me in the system that I had. It prevented me from making medical errors that I am extremely grateful I did not make. It made me a more efficient utilizer of healthcare resources, and it helped me deliver better quality of care. I will come back in a moment to, or in a few moments, to the question of why I think the adoption of this technology is inevitable. And the reason is not fundamentally economic. It's fundamentally about this value proposition that I think will become evident to the users of electronic health records. Okay, what I'd like to do in the few moments that I have with you is to talk about these issues. I'd like to talk about the problem that we face, just very briefly, the role of health information technology in the solution of that problem, what I perceive the barriers to moving forward with health information technology are, how the HITECH Act, which I'm charged with implementing, addresses those barriers. And then I'd like to say a word about professionalism and its role going forward. So this is a truism. We face problems of cost, quality, and access. We spend every day throughout this country decisions that are made by health professionals and by patients result in unnecessary expenditures of hundreds of billions of dollars, and also jeopardizes patient health and our economic well-being in the country as a whole. Though I agree with Ken that physicians try very hard to keep up, I think there's a pretty robust literature that shows that they fail at that frequently. And that's true not only of physicians, but of all health professionals. And one of the results is that quality is not as good as it could be. And of course, it's not just lack of knowledge, it's also system errors that reduce quality. That remains a fundamental challenge that we have in our healthcare system. And of course, this slide, which talks about 46.8 million uninsured, is obsolete as of last week, because we know that the number of uninsured in the United States now exceeds 50 million. One of every 6 Americans lacks insurance. And I know that's a particular problem in the state of Texas. So why health information technology? What is its role in addressing these issues? Well, I like to use the analogy of a circulatory system. Information is really the lifeblood of medicine and healthcare. Every doctor, every nurse, every respiratory technician, every physical therapist is only as good as the information they have about the patient who is sitting or lying in front of them. And health information technology, I think, is destined to be the circulatory system of that information. And that's why I have on this slide these rather two incongruous images of a cartoon of a circulatory system and a bust of Hippocrates. Because our current circulatory system for health information, our lifeblood, was invented actually before Hippocrates. It's the same one that Hippocrates used. It's paper and pen. Could have been quill and parchment in those days, but that's not a big advance. And we are living with a technology that does not in any way do justice to our ability. Someone making coffee up there? To our needs and ability to use information. As I mentioned, I learned to practice in this world. Clipboards, Harrison's textbook of internal medicine, which I used to lug around in medical school and still have on my office desk when I left practice 17 months ago. An inbox full and a paper prescription. I have 2 children in medical school. This is the world that they will practice in. There will be a whole array, at this point probably mostly unimaginable, especially to people of my age, a whole array of technologies that will empower them to be present and effective with their patients in a way that we couldn't dream of, certainly that I never anticipated in my computer-free training world in medical school and residency. And this is, right now, what the core technologies are that create the value that they will realize and build upon going forward. There's, first of all, the electronic health record. Now, the electronic health record is what it says it is. It is a record. Inherently, it's a repository, a place where information in digital form is kept. And it's needn't be passive, but it is basically passive in the sense that information is put in there and waits for it to be summoned up and used. The more powerful aspect of this set of technologies have to do with health information exchange and clinical decision support. I'm going to talk a little bit about each of those. First of all, health information exchange. At its most basic level, and this is a basic description I'm going to share with you, health information exchange is about moving data in an electronic world to replace the movement of that data in a paper world. So here's a schematic of how, right now, most physicians and most hospitals and most nurses move information around the healthcare system. On the left, there is a message. It's written down, but it's written in a vocabulary and with a dictionary to back it up, and it's understandable to someone who has that dictionary and understands the language. The sender finds an address or a telephone number in a directory, puts it in that venerable technological package called an envelope, seals it, puts it in the mailbox. The mailbox carries it. That's also, by the way, a technology. All the things that happen to your letter that are invisible to us, very complicated technology. Something that you can put something in an envelope right outside this door, and 2 days later it'll end up in Washington, D.C. at the right address. That is a very complicated technological undertaking. When it arrives, it is sealed. I don't know if you can you see this? It is sealed. Now, what is that about? That's about security and privacy, right? I mean, and it's actually illegal and a felony to transgress on that. That's mail fraud, to get into that illegally. And it shows up in the inbox or the mailbox of a physician or a nurse, and information is transferred. At its simplest level, health information exchange recreates those processes in electronic form. So, first of all, you create an electronic vocabulary. You have to make sure that the digital definition of the terms that we use as doctors and nurses, as patients, are consistent across different machines, different software packages, different systems of care. So you need a digital vocabulary. Then you need a way of sending. You need an envelope, if you will, an electronic package in which to put that message that's contained in those words and in that grammar that the vocabulary has put in place. You need a place to send the digital message. And that means an electronic directory, an electronic destination that is reliable and as secure as the mailbox, the mail address that we now take for granted. You need an actual process of transmitting that message in its envelope across time and space to the directory and the address where you intend to send it. And of course, it has to get there. It has to get there with the same reliability as the U.S. mail would get something, actually better than the U.S. mail. And when it gets there, you have to be sure that it hasn't been intruded upon. No one who shouldn't have access to it has looked at it. So the envelope is still sealed, if you will. And you can do that through encryption. You can also do it through privacy protocols of various kinds. And one of the important things, of course, is that there be consequences for entering that envelope when you're not supposed to, criminal and civil penalties. Now, having said all this, that's the technological side of it. That is the easy part. The technology is the easy part. Because information exchange is really a team sport. You'll forgive me for putting the Boston Red Sox up here. It's my hometown of Boston. But in some ways, it's an even better analogy is a basketball team. So you can pass. You can be a great passer. You can be a great one-man shooter, one-person shooter. But if you pass the ball and there's no one there to receive it, that ball goes out of bounds. And you can't beat a team of 5 when you're only 1. Now, what does that mean in concrete terms? It means that information, which is now tends to be collected in individual organizations or in individual practices, which is looked at often as a proprietary advantage, which has value, if not directly for its economic benefit, it has value in terms of its ability to tie patients, customers, to the place of service that has that information. That information has to be shared. Now, even if you don't have any economic rivalry with the recipient of that information, you have to trust that that other party that you want to share information will keep it secure and private and won't share it with a third party who doesn't have the right to it or isn't authenticated to have it. Basically, what you have to do is build a community. You have to build a community of trust, a team that has rules and regulations and that plays together and learns how to play together. In other words, you need collective action. Think about our political culture in the United States and how well we are able to do things collectively on a regular basis without the help of public leadership. And I think you begin to see the fundamental social, political, and economic challenge we face in creating health information exchange. That's why I so celebrate stories like the stories that Bill Stead were telling about the success of exchange in Tennessee. And there are other examples of that around the country. But they have all grown up based upon trust relationships, overcoming economic rivalry, overcoming historic schisms in local communities. And that's the challenge that you in Texas will face at a very fundamental level if you want to take advantage of health information exchange, which is vital to giving patients the value that they should be getting. Because ultimately, information should follow patients. It's their information, it's about them, it's for them, and they deserve the benefit of it and the benefit of the skills that physicians and hospitals can bring to bear once they have that information. Now, clinical decision support is a whole set of technologies that aim to make clinical decision makers better at what they do. They include things called algorithms, order sets, guidelines, institutional policies to encourage evidence-based medicine. In their more refined form, they come to resemble the learning process that Bill Stead described, where you learn from your experience, build that into new algorithms that then improve the level of care and become the next platform upon which you build again. It can help providers document. It can help them be more efficient at the care they provide. And it can help them reduce the utilization of care by avoiding things that are unnecessary for a given clinical situation. And here I'm referring in this line to CPOE, or clinical provider, computerized provider order entry. Clinical decision support is what makes computerized provider order entry worthwhile. Because what it does is it says, It looks at the order, and it says this order should be informed by information that is in the computer about the patient, or information that has been generated through research, or information that has been, or advice that has been agreed upon by the collectivity of the profession about what best practice should be. That is where the value proposition for doctors and patients and society as a whole and nurses begins. It's at the application of clinical decision support to the entry of orders on behalf of individual patients. Now, just as a specific example, one of the most robust areas of growth in our healthcare system is advanced imaging. MRI, CT, ultrasound, and all the complex applications of those multiple technologies. And as you can see, looking at Medicare data, there's been a very, very rapid increase in the use of imaging for Medicare patients, consisting to a large degree of CT and MRI related uses. I mentioned the value that I found in clinical decision support when I was using electronic health record. And probably the best example of that is a story about a patient who came to see me and who I thought needed a abdominal CAT scan to have her kidneys imaged. And fortunately, at where I was practicing, there was a clinical decision support system called radiology order entry. And what that did was it required that I put in the indications for the test I was ordering in terms of diagnostic information and symptom information and history information. And then it would compare my order to the guidelines from the American College of Radiology. And it would do that in real time, so there was no waiting for that. And then it would give me back feedback of the type that even a busy physician could understand: red, yellow, green. Green is okay. Red is you need to have a good reason to do this. And not only that, but it would look back at the other tests that the patient had and try to find if anything like that had been ordered for that patient within a 3-month period. Well, when I ordered this CAT scan, it gave me a green. That was nice. But it also said, you should look because something like this has been ordered for this patient within the last 3 months. So I went back and looked through the recent radiology. There was no abdominal CT scan, but there was a chest CT scan. And the clinicians in this audience will know that often when a radiologist does a CT of the chest, they will go down below the abdomen and get part of the abdomen as well as the chest. And sure enough, on that thoracic CAT scan, there were the patient's kidneys. She didn't need that abdominal CT scan. I saved her the radiation exposure, and we now know that that is an increasing threat to health, the origin of a non-trivial sort of number of cancer cases in and of itself. It saved the healthcare system a lot of money, and it saved the patient the inconvenience of coming and potentially the exposure to contrast media to which she might have been allergic. Now, all that was done in a totally non-coercive way. No one was telling me I had to do anything different. It was making me a better physician, a better decision maker. And if you can imagine that kind of benefit brought to thousands, tens of thousands, hundreds of thousands of decisions throughout this country every day, you can see how we could bend the cost curve down and the quality curve up in a way that has makes absolutely no intrusion on clinical autonomy in this country. To me, that's a total win-win. Meanwhile, the consequence of the use of that technology is apparent in this slide. This is a publication in radiology by one of my colleagues from the Mass General in 2009 that looked at the temporal trends in the ordering of outpatient CT exams at the time when this particular clinical decision support was made available. As you can see, the trend in the ordering of CT exams leveled off in our health system at the time when this new radiology order entry software became available. Now, there is still sometimes question about whether electronic health records bring value to healthcare in terms of cost, quality, efficiency. I think that the literature has been up and down on that subject, and because there are both positive and negative studies, I asked my colleagues at the Office of the National Coordinator to review the recent literature. They looked at studies published in the last 2 years, building upon previous reviews of the literature. These are all peer-reviewed articles since 2007, and we focused on on concrete outcomes, effects on quality of care, effects on efficiency and cost of care, effects on provider or patient satisfaction. These results are not yet published, but they've been presented at several scientific meetings. I won't bore you with this paradigm, but for the investigators here, we started with over 4,000 studies, and by the time we got down to the ones we thought were worthy of inclusion, we ended up with 154 studies. So these results reflect the conclusions with those 154 studies. 92% of them were positive or partly positive. We say mixed here because they were not exclusively positive. So the overwhelming reports in the peer-reviewed literature about the effect of electronic health records and their various applications on one of these outcomes, cost, quality, or provider satisfaction, or efficiency, were positive. They tended to be more positive the more holistic the applications were, which is consistent with the idea that if you have exchange and decision support combined with the record itself, you get more benefit. So this was very, obviously, since we're in the business of spreading these records, this is very encouraging. And hopefully this will get published and be available for the criticism of the community as a whole. It still, given this experience, may seem puzzling to some of you that this is the story of adoption of electronic health records in the United States. So this is data from the Commonwealth Fund that looks at rates of use of electronic health records in the US and Canada compared to other advanced industrial economies. For more advanced functions, those electronic health systems reporting at least 14 particular capabilities, the numbers remain low. And this is the rates, the most recent rates from the National Ambulatory Medical Care Survey, which is the best source of reliable national data on the adoption of electronic health records. And what it shows is that 14% of physicians in 2008 had a basic electronic health record, 6% had an advanced electronic health record, and 80% didn't have any, but 37% said they were planning on doing something about that. But still, not a very encouraging basis upon which to build the kind of learning capabilities that Bill Stead talked about in his earlier talk. Hospitals are not very much better off. Matter of fact, they're worse off. 13.5% of them had a basic electronic health record in 2009, 2.7% what was defined as a comprehensive, though there are large numbers that have pieces, though they haven't put them together into something called an electronic health record. By the way, this is from the American Hospital Association's annual survey of American hospitals. Now, why is this the case? What are the barriers to electronic health record adoption? Well, the first two are money, either lack of capital or uncertainty about economic return on investment. And down the line here, less prevalent, but in the same general category, is a fear about loss of productivity. These data, by the way, report the response to the same question by physicians who had an electronic health record and physicians who didn't have an electronic health record. Also important, though, were in this middle area, concerns about finding a system that meets your needs, or about a system becoming obsolete, or about inability to implement, or concerns about inability to implement. This is a very big decision for a physician or a hospital. Finding the right technology reminds me of the time when I was much younger, when the question was which calculator to buy. And every time you got to the store and looked at the sampling, you would stop and say, wait, next week it'll be better. I'm going to wait. The same paralysis can set in with physicians and hospitals, especially smaller ones that lack expertise, trying to decide which system to buy. And part of that anxiety is about what will happen once they buy it. And will it be the right one? And will they be able to maintain it? And what unpredictable catastrophes are going to paralyze their practice? Change is always hard. It's always a psychological struggle. But to add this technological and logistical fear just complicates the difficulty of change. Now, fortunately, when I got to Washington in April of 2009, the Congress had already passed and the administration, the president had already signed the stimulus legislation, the American Recovery and Reinvestment Act of 2009. The legislation that I am tasked and my colleagues are tasked with implementing is part of the stimulus bill. It's called the HITECH Act, the Health Information Technology for Economic and Clinical Health Act. The reason I was so fortunate is because this legislation addressed all the barriers in one way or another that providers perceive to the adoption of electronic health records in a very systematic way. They address the issue of technical support and logistics. They address the issue of money, and more comprehensively, they addressed the core issue of lack of funding, which is a market that doesn't work. I'll say more about that in a moment. They also address the issue of the lack of teams for health information exchange and the need to create an infrastructure for health information exchange. And I didn't talk about this as a barrier, but it's a barrier for non-clinicians more than for clinicians. It addressed issues related to privacy and security of health information. This is a complicated slide, but basically it summarizes everything my office is trying to do. Starting on the right, we are focused on improving health and system performance. That's what we're about. We're not about technology installation. We won't be happy if everyone adopts electronic health systems and nothing changes for patients. That's not our goal. That would be great for the vendors of electronic health systems. It would be great for economic growth, but it wouldn't be good for what our real purpose is, which is to make people healthier and to make care more efficient. It also wouldn't be good necessarily for the ability to learn from the information gathered in healthcare. So how are we going to get to this outcome using this new technology? Well, the first thing we need to do is get people to adopt electronic health systems. We need them to exchange electronic health information. And the key to unlocking that, to a large degree, is meaningful use, a term which attracts most of the attention around the HITECH law, but is also a means to the larger end of using health information to improve health care. And meaningful use is, in part, the solution to the market difficulties and the money difficulties. It puts on the table substantial new funds for hospitals, clinicians of various types if they become meaningful users of electronic health systems. But adoption is, the money's important, but we need other kinds of help to get physicians to adopt. So we've created regional extension centers to provide technical assistance at the local level. We are creating a new workforce to staff those regional extension centers. We want people to exchange health information, and to do that, we've funded states to get them into the leadership position on creating health information exchange. We're creating standards. Remember, we need those vocabularies, those envelopes, if you will, for sending information around and exchange protocols. And we're also working on privacy and security. So all this fits together in an intentional strategy that has many moving parts. A little more on each of these pieces. Medicare and Medicaid incentives through the Meaningful Use Program put on the table between $9 and $27 billion in extra payments to providers for being meaningful users of electronic health records. That's $44,000 in Medicare funding, or up to $64,000 per physician in Medicaid funding, starting in 2011 and extending through 2015. Hospitals can get a $2 million bonus plus an extra per discharge payment, which can be as high as, which maxes out at a certain number of discharges, which is over 20,000. And then my office was granted $2 billion to build this state, the multiple other programs that I described to you on the previous slide. We've put into regional extension centers almost $700 million. We've built a network of now 62. We just funded an additional couple of regional extension centers, so we're up to 62 now. They're supported by a health information technology research center, which is really a technical assistance capability for regional extension centers to make sure that they learn from one another and to spread the practice knowledge that they gain in supporting physicians in adopting electronic health records. Regional extension centers are prioritizing primary care physicians in small practices and underserved areas. And they're also prioritizing critical access hospitals. We think that those are the most vulnerable physician and clinical groups in our healthcare system. We don't have enough money to provide equal support to everybody, so we're putting the support where we think it's going to have the best payoff in the short term. And we're putting $120 million into training over 40,000 health IT personnel to be available to clinicians and to regional extension centers to actually sit with physicians and nurses and others, helping them get past the obstacles to adoption. We're putting $560 million, which 28 came to here in Texas, into funding states to be leaders, as I said, to be conveners, in some cases actually to run health information exchange capabilities, but just as often to convene the relevant parties and try to create those teams that are so essential for health information exchange. And we have produced regulations specifying certification standards and certification criteria. We've created a certification process for electronic health records. This is required by law, but it's part of the job of helping clinicians get past the fear factor by having a federally created certification process saying essentially this electronic health record is capable of meaningful use, of meeting the requirements that the federal government will have, but also implicitly capable of meeting your needs as a clinician. And we are working not only on the politics, economics, and sociology of exchange, but also on developing new channels for exchange that will be simpler and easier to use. Privacy and security. In this room, I don't know what the makeup of this audience is, but I can guarantee you that if this were a room made of the average American, the average citizen, an audience of that type, their major concern, aside from knowing that their doctors and hospitals knew about them, would be that what they knew about them was safe and secure and private. And we know we have to meet that test in order for these sets of policies to go forward. And HITECH, the Act, did that in a series of ways by strengthening penalties for negligent breach of health information, by banning the sale of health information without patient consent, by creating ongoing requirements for institutions that have electronic records to audit who has access to those records to make sure that only authorized people have access, by giving patients increased rights to their own information, and also by telling my office that we need to work on better encryption technologies, which we're actually doing with the President's cybersecurity coordinator. Now, meaningful use gets a lot of attention because it's associated with a lot of money. Meaningful use is actually a regulation of the Center for Medicare and Medicaid Services, not of my office, and they played the lead role in developing it. But we were pleased to help think about it with them. It has 5 pillars. Basically, all the requirements related to meaningful use are organized around 5 healthcare objectives. First of all, patient and family engagement. Secondly, coordination of care. Quality, safety, and efficiency of care. Privacy and security. And population and public health. We've had some discussion today about the purpose of technology as being for achieving quality goals, efficiency goals, healthcare goals. That is the purpose of the meaningful use objectives. There isn't a single piece of that meaningful use framework that can't be related to one of these 5 objectives. And if there is one, it shouldn't be there. But we had over 2,000 comments on this regulation and multiple public hearings and public conversations. And we sensed pretty good agreement by the end of that process on what was actually contained in the regulation. Meaningful use. Again, it's not about the technology. It's about making use of the technology for a public purpose. It is easy to look at what is in the list of meaningful use criteria. If you ever have that experience, you will see that there are lots of fine-grained objectives that meaningful users have to meet. They have to do with things like recording patient demographic information, including, by the way, race and ethnicity for a certain number of your proportion of your patients. They have to do with maintaining an up-to-date medication list, maintaining an up-to-date problem list, including having a drug allergy check, having a drug-drug interaction, sharing information about a visit with patients within a defined time frame, giving patients access, electronic access to their health information, and quality reporting. Now, those things by themselves don't seem like they're going to be an overwhelming influence on the big outcomes of care, but they are foundational. If you don't have the information in the record, you can't use the information for more advanced purposes. We faced the challenge of taking a country where adoption by physicians is in the low 20%, adoption by hospitals is in the high teens, and moving them forward without getting so far ahead of them that the clinical population basically said, sorry, not going there. Essentially what we had to do was get them on the escalator toward increasingly sophisticated and beneficial uses of digitized health information. So we started with the basics. We started with capturing and sharing data. The kind of things nurses, doctors, hospitals know they need to do to take care of patients. Know the patient's age, know their diagnoses, know their medicines, know their laboratory results. And we added a few things that we hope will bring us to the next stage of meaningful use. And by the way, there will be other stages. We are expecting in 2013 and 2015 to elaborate additional criteria and requirements for meaningful use. And we expect those to be increasingly focusing on those high-value functions that I illustrated earlier, clinical decision support and health information exchange. And then we want ultimately to move to a focus on improving outcomes, to getting hospitals and doctors and nurses to say, this information is here for a purpose. And that purpose is to improve patient health. And what do I need to do to improve patient health? I'm going to skip this slide because you can find out what's in meaningful use on the CMS website or our website, and this is very high level. I do want to say that we face substantial challenges. We have created all our programs, we have written our regulations. There's still a few of these to go, but mostly we've accomplished what we need to do to be prepared for January of 2011, when meaningful use becomes possible. But we are still at the beginning. We need to get our regional extension centers up and running. We need to develop that infrastructure for exchange. We need to get teams forming around this country who are working to make exchange happen and motivated to make exchange happen. We need to have the workforce there that we're training. We need to create an economic case for adoption and exchange. Meaningful use has created a market that never existed before for the adoption and exchange of electronic health records and exchange of health information. Health reform and its still relatively undeveloped health system changes, which are later out in the legislation, so they've gotten less attention, will be, I think, really important in creating a sustainable case for electronic health systems. And as I mentioned, we need to define the future stages of meaningful use. And this exercise will be every bit as hard, in fact, harder than the first go-round. Now, I mentioned at the beginning professionalism. And there are many reasons, I think, to adopt health information technology as an individual clinician, nurse, physician, a respiratory therapist, whatever you happen to be. But I think one of them has to do with the definition of professional. So professions are defined sociologically by three characteristics. The first is unique competence based in science and a demonstrated capability to use that science to add value to society. The second is self-governance through professional organizations. And the third is a set of moral and ethical commitments that compensate for the fact that the unique competence of the professional gives them an advantage over the clients and patients they serve, an advantage that could be abused if they weren't bound by moral and ethical constraints. I think that within 10 years, the use of electronic health records will be a core competence for medical professionals, as important as the use of the stethoscope, knowing how to make it, to open and close an incision, knowing how to order the correct x-ray or administer that x-ray. Now, why do I say that? Remember, we are only as good as the information that we have to put at our patient's service. Only as good as the information we have. In other words, information management is a core technical competence right now in the paper world. And yet we know that the technology we use to manage that information is woefully outdated, and there is a much better technology that increasingly is demonstrated scientifically to be better. So the question is, how can you be a modern professional and claim unique competence, justify your licensure, justify your board certification, if you don't take advantage of available, better technologies that are integral to performing the valued functions that you provide in society? Now, I'm not the only one who thinks that. The boards of certification for specialty societies are going in the same direction. The primary care boards have already committed themselves to incorporating into board certification some measure of electronic competence. The American College, I suspect that other specialty boards will be going in that direction as well. I think the boards, the groups that certify residencies are going to do the same thing. If academic health centers and teaching hospitals don't teach residents and interns and fellows to use electronic health records. And I even think that within a decade or two, there will be maintenance of licensure requirements for physicians and nurses that will require that they show competence with electronic health records. And this isn't some government-imposed idea. This is coming from within the profession, as the profession recognizes that in the 21st century, the Hippocratic Oath and Hippocratic technologies do not have to go together. So I want to just show this slide, which I find very revealing. This comes from the Journal of the American Academy of Pediatrics 150 or so years ago. And it reviews the adoption of the stethoscope as a new technology. And it confides that the author is extremely doubtful that this will be adopted because it requires so much time and because it's opposed to all our habits and associations. I think a lot of the literature about the electronic health system and the obstacles to its adoption in 100 years, 50 years, could be lumped with this article. And I don't think it requires that we be visionary or even impractical to suggest that we are at the beginning of a very rapid and momentous change in the way health information and healthcare are managed in the United States. So, you can tell I've been converted. Thanks very much for your attention. I'd be glad to take some questions. Ken.
You emphasized the desire to get to decision making and so forth out of 2013. We've been, we have a project in which we're looking at meaningful use across all of our campuses with the idea of getting agreed upon set of quality that we can then use to measure outcomes and compare performance, et cetera, et cetera. What worries me is that while Medicare and Medicaid implements software and hardware in physicians' offices, that software or hardware itself may not provide the platform for the kind of decision-making you're talking about. So how are you dealing with the notion that they may be right? That is, that they may find that something is appropriate for the electronic health record portion for the next couple of years, but is not necessarily the platform which will allow real decision-making support long-term.
Well, one of the things we've been doing, so the fundamental flaw in this ointment is, the fly in the ointment, is that there is no market for better performance. You don't get rewarded for lower cost, and you don't get rewarded for higher quality. Meaningful use creates a market for electronic health systems that support better performance. And part of what we're going to be doing is telegraphing to you, the provider, and to vendors, the kind of message that I've been talking about right now. And by the way, it's not just in my slides, it's in the preamble to the regulation. The preamble says very clearly to vendors and to any providers who care to read it, we're not stopping where we are. We're heading toward clinical decision support, toward health information exchange, toward high-value functions. So if you want to be ready for meaningful use in the out years, you better look for records that provide that capability. And if you're a vendor, you better provide that for people who are going to be asking for it. Now, we can't jump people halfway up the escalator when most of them are not even decided yet whether they want to put their first step, whether they want to get on the first step. It wouldn't have worked if we had said to them, in the first year of meaningful use, we want you to show us how you've improved blood pressure control, diabetes, asthma, coronary artery disease, congestive heart failure treatment, and we'll pay you if you've reduced readmissions by 10%. Otherwise, forget it. No incentive payment. And there's one fundamental characteristic of all this, and as I said, if the information isn't digitized, it can't be used. So we had to start at the ground floor, and that's where we started. Now, for folks like the University of Texas, for folks like my own partner's health system in Boston, who've got the basics are not necessarily easy, the first stage of meaningful use, but it's not very intellectually interesting. And we understand that. We're going to try to catch up with them. And we're going to hope that the market works with the messages we're sending. Ultimately, the best incentive for changing the capabilities of electronic health records is if providers conclude that they need to improve performance and telegraph that in their purchasing decisions in their choices of vendors. And then the vendors come back and say, to sell into this market, I have to sell a different product.
Have you seen any movement by the major vendors to actually do that?
Well, to be certified, and none of them have been certified yet, they are going to have some clinical decision support, and they're going to have to be able to report quality metrics. So we have begun to build that in. To be certified in stage 2, they're going to have to be able to meet stage 2 objectives, which are going to be more demanding on information exchange and more demanding on process improvement. So I think a smart vendor would be building that in, but I can't tell you yet because we haven't, seen the response yet. The money, 2011 is when this project starts, really. Yes, sir.
Hi, Dr. Blumenthal. Thanks again for coming to Houston. I'm Jack Smythe, president of Spring Medical Systems, and we are one of these vendors that seem to be bashed a lot today. The Electronic Health Record Association is a group of 43 vendors that are working very, very closely with the Office of the National Coordinator to make sure that our technology does have the capabilities that will provide not only the meaningful use first stage, but we're already starting to work with the various groups to make sure that what we're collecting today can be used in the future. And I want to just make sure everybody understands that what Dr. Blumenthal is saying, that you have to walk before you run, and we have to get all these doctors and hospitals to start collecting the information so then we can really turn it into meaningful use. So thanks again for coming and addressing us.
The availability and permanence of medical records and the kind of detail that's been described would present, I would think, issues around malpractice insurance, product liability for medical providers, differences in medical products and pharmaceuticals, et cetera, that could lead to either a better situation vis-a-vis the legal situation or a far worse one. Have you touched on that at all?
Well, we are very encouraged that liability carriers, malpractice insurers, are very anxious to see providers adopt electronic health records. So they think it's going to save them money. And that, to me, is pretty good market evidence that this is a technology that is inevitable, because eventually that track record is going to catch up with the market. That's not to say that there won't be new problems that arise in an electronic environment that will need to be managed. I mentioned that the mail system is a complicated system. It started with the Pony Express. We're a little better off now. Pony Express was better than what preceded it. We're going to get, over time, to a reliable electronic health system But for the moment, given the way people in this country cherish their freedom and their independence and their right to pick their own course in life, we're going to have to let people choose their own electronic health systems. They're going to vary. Some are going to be pretty usable. Some are not going to be so usable. Some are going to have software flaws. Some are not. Some are going to result in problems that others won't. I'm pretty sure the carriers will figure that out. The liability carriers will figure that out pretty soon. I know they're already thinking about ways to get more systematic information on precisely that topic. So, I think there's no question that this is a hard thing to do, and that it will create dislocations in office practices and dislocations around nursing stations. But there's also no question that the folks who have made this transition, and we surveyed physicians a couple of years ago before I got into government, 90% of them said they were satisfied with their electronic health record. And I was over at Ben Taub Hospital this morning talking to their folks, and they were saying you couldn't rip their medical record out of their physician's hands at this point. So that's going to change. We're just going to get past this barrier. We will.
What do you think is going to be the role of government in terms of incentive systems using EHRs for improving quality 10 years down the road? Because right now you've issued specific, sort of, you might call them narrow, but very useful guidelines for how physicians need to demonstrate meaningful use. But is that list going to grow over time, or is it going to be more global measures that aren't going to be related to federal awards? I
think the list will, and again, I'm looking through a glass darkly here, and we have, by the way, a very complex, robust advisory system about what meaningful use will be and should be in the future. And we've actually already convened our maiden advisory committee, a Health Information Technology Policy Committee, to begin the process of discussing the next stage of meaningful use. And we will want to see what happens in the first stage of meaningful use. But my guess is that the data collection will be a non-issue very soon. And after that, we will be balancing the requirements for more advanced practices. And in a way that will certainly lag behind the capabilities of a Vanderbilt or University of Texas or Partners Health System or many other places, Intermountain, Mayo, we can all think of them. They will look on these and say, we did that 5 years ago. But in the meantime, we will be raising the level of community practice in a gradual way, taking people up the escalator. And the incentives will be tied to those increasing levels of performance.
One of the 5 goals that you had up there for meaningful use was for public health. And as you look towards the future of a national health information network and bringing this data together through health information exchanges, how will you balance the privacy, security, the current regulations with HIPAA with the need to bring together identified patient information for longitudinal analysis and for public health research?
Well, there are very narrow areas where identifiable information is now made available without patient consent. Okay, so it's for treatment purposes, from provider to provider, as in the paper world, for payment of claims, for clinical operations, so that the admitting office can know your name, and what your diagnoses are and whether you need to be in an isolated bed or not, and also for public health reporting. And each state has its own reportable illnesses, And those reporting requirements have been accepted as more important than the right to privacy. Meaningful use will support those reporting requirements over time electronically. As immunization reporting to public health authorities is already a part of meaningful use. At some point, we will also, and by the way, Medicaid agencies can exceed our meaningful use requirements for Medicaid providers in the public health area for state-specific requirements. So we will, for that aspect of the collection of identifiable data, I think there's a fairly clear path that's well accepted in the paper world and will be well accepted in the electronic world. There are a whole series of other uses of electronic information for which identification and de-identification, privacy and security will need, I think, new regulation or new law in order to provide the average citizen a sense of confidence in the electronic systems that are being built throughout the country. Oh, okay. I'll take one more.
Hi, Laura Peterson from the Houston VA and Baylor College of Medicine. Nice to see you again. So I'm really fascinated by when you're speaking about adoption of this technology and how to encourage providers to use them. Why you haven't thought about incorporating a principle from behavioral economics, something like an opt-out. So we have a federal EHR in the VA that's already been developed, that's available for $25 with a FOIA request. And you could say that that is the default program unless you opt out and want to spend millions of dollars somewhere else. So it seems like we really aren't harnessing the potential of creating some incentives for this technology adoption and moving things forward a bit faster. What are your thoughts about that?
Laura, I'd love to talk more about what precisely you had in mind. The VISTA system, the VA system, is available in the commercial market right now. It's supported by several consulting companies. It is not sold well. The market has not embraced it. There are a lot of complicated reasons for that, which I don't want to bore you all with, but it is available as an option. Other systems seem to be meeting users and end users' needs better. So to require or give the appearance of requiring that providers or favor the market, give preference in the market to a particular product, I think would A, be politically difficult, B, I'm not sure good for innovation, and C, I'm not sure would actually achieve our healthcare goals. Because if there are folks who are adopting other products and find them more compatible, it may be, in fact, that they're meeting their and their patients' needs better. Thank you very much for your attention. Good luck with your conference.
Well, thanks, Dr. Blumenthal. I know we appreciate the support. The state of Texas appreciates the support, and I know the people in this room won't let you down on that. We're going to take a 10-minute break to allow our panel to get set up here, and so we'll meet for another 1-hour session after that. So we'll meet at 1:10. Thank you.